Welcome everyone to the Opioids Friend or Foe webinar with Andrea Furlan. This is the third webinar in our current series that we're running on chronic pain, improving life while living it, and we're glad that you could be here today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar is co-sponsored by ourselves as well as with Pain BC, and we're also in collaboration with the Canadian Pain Coalition, and it's been made possible through the support of the Direct Access Program through the BC government. As I mentioned, my name is Tanya and I'm moderating. Also joining us today is Lisa Mighton, who will be collecting questions and helping us sum them up during the question and answer portion. And then our presenter today is Dr. Andrea Furlan. She's an associate scientist at the Institute for Work and Health. She's also a member of the editorial board of the Cochrane Back Review Group, a physician at the Toronto Rehabilitation Institute, and an assistant professor in the Department of Medicine's Division of Physiatry at the University of Toronto. Her main research interests include chronic pain, lower back pain, and neuropathic pain. And so I'd like to hand it over to her now to start the presentation. Thank you for being here, Dr. Furlan.
Okay, thank you, Tanya, and thank you, Lisa, for the invitation to be here today. I'll be talking today about something that is very dear to my heart, which is the use of opioids for chronic non-cancer pain. So my talk is basically for people who have chronic pain but not from cancer. And this includes things like low back pain, fibromyalgia, neck pain, arthritis, these kind of things. And I'm very happy that you invited me, and I will try to share with you some of the wisdom that I've learned in the last couple of years that I've been involved with the opioid guidelines in Canada. So I put a picture here of me because I'm not used to have an audience, a virtual audience that I don't see people who is watching me, who is listening to me, but I put a picture so then you can at least see me and see who I am. So I will, let me just go to my next slide here. Oops, for some reason the slide's not, okay. Here. In terms of conflicts of interest, I put this slide there because just to show that I don't have any conflicts of interest with any pharmaceutical industry. I never had any money for my research or for my education or educational purposes from any pharmaceutical industry, only some honoraria and grants for my research. And I also will be talking about the Opioid Manager app, which is an app for iPhone and iPad. But it's not owned by myself, it's owned by my hospital, the Toronto Rehabilitation Institute and UHN. When I press the button here, it's not changing my slides. Okay, sorry about that. I think might be some delay here. So the objectives of my talk are to explain what are opioids in your brain, what are endorphins, what are opium, where they come from. Also to talk about some myths and realities about addiction and opioids. I'm not an addiction specialist, but I prescribe opioids for my patients with chronic pain. So I have to know what they do to the brain and the possibility of causing addiction. Also, I'd like to tell what the doctors may be thinking when they prescribe your opioids, when they prescribe your painkillers, and tips to talk to your doctor about your opioid medication. So every time that you see this symbol here, the tips, it's because there is a tip there, and I will summarize them at the end. I came up with 12 tips during my talk. So when you see this symbol coming up, it's because there is a tip to talk to your doctor. So I'd like to introduce you to one of my patients, and we did a TV show for Global last month. So Ricardo is a patient of mine. In 2006, he was 28 years old, and he suffered a motorcycle accident here in Toronto. It was a big accident. He had to be rushed to the hospital. And he was in coma for 2 months due to a brain injury, and also he sustained sustained fractured ribs, fractured pelvis and femur. He had perforated lungs. He had a brachial plexus injury, which means he was left with a left arm paralyzed. And he has a chronic neuropathic pain, it's a nerve pain in his left arm. So in terms of his pain, it was very intense. When I saw him the first time in 2008, the pain intensity was 10 out of 10. It was affecting his left arm and left hinge. It was constant, 10 out of 10. But about 20 times a day, he had some very strong episodes of electrical shock-like every day. And these episodes, he never knew when they were going to come. And they lasted a few seconds or minutes, and they were excruciatingly painful. And he was also left with the paralysis of his left arm. So the treatment plan for Ricardo, we treated him at Toronto Rehab from 2008 to 2011. He's still my patient. I still see him regularly, but now less frequent. So the treatment included physiotherapy, occupational therapy. We had to provide him some arm support and also some medication so that he could endure all these exercises, the therapy, and to try to improve his pain. We were not trying to recover the function of his arm because we knew this was going to be a permanent disability. But to try to improve his pain, we had to do a lot of interventions, including antidepressants for his pain, anticonvulsants, and opioids. So, but before we prescribe opioids, and that's me with Ricardo, and I use the Opioid Manager, which is a tool to help us doctors to decide when we are going to prescribe opioids. What are the things that we have to do before we give the first prescription? So, of course, we have to assess, is this patient at a risk of overdose? Is this patient at a risk of addiction? What is the mental status of this patient? Is this patient depressed, anxious? Does this patient have social supports? What are the patient's goals with treatments? Do the patient have realistic expectations with this treatment? Does the patient know what are the adverse effects? There are complications, and we have to focus on the functional improvement. So all of this, in the case of Ricardo, they were all in his benefit. He didn't have any big risks. His expectations were very realistic. He wanted to improve his pain so then he could get a job, because at that time he lost his job and he was trying to look for something, some gainful activity in his life. So then we proceeded with Ricardo. His goals were achieved because now he's self-employed. He was not able to go back to his previous profession, but he's self-employed. He still has the paralysis of his left arm, but his pain is under control, which means he still has pain, but those 20 episodes of excruciating pain, they don't happen anymore, but he still has some basal pain. He's not on opioids anymore. We were able to stop them slowly and tapering slowly and gradually, so he would not have those withdrawal symptoms. He's now only on anticonvulsant medication for his pain, and his goals were achieved, which means that he's self-employed, he's happy, and he's very functional every day. So what are the opioid medications? Why everybody talks about opioids and the problems of addiction and diversion and illicit use of these opioids? It's basically because opioids are medications that they come from opium poppy seeds. The name is Papaver somniferum. They're also called narcotics because they were used many thousands of years ago to make people to sleep. And if you see, this is the plant, the poppy, the opium poppy plant, where we get our poppy seeds from, or bagels or breakfast. Of course, nobody gets sleepy and nobody gets analgesia, pain relief, when eating a bagel with poppy seeds. But if you eat a bagel with poppy seeds, you may detect, and if we do a urine drug screening, we may detect opium in your urine. So people should know that. But basically, it's the latex coming from the plant. You see the flower there, and where you see these white dots coming? That's the latex of the opium plant. And this latex is very, what it's contained there is morphine and codeine. And people use the morphine and they do some acetylization and they convert it to heroin. So heroin, everybody knows, is very addictive. It was invented by Bayer and distributed in the 1900s as a pain medication, but now we don't use heroin anymore for pain. However, the other medications, the natural opioids, and this is a table that shows the natural opioids. They are in the first column. They're called opiates. It's morphine and codeine because they are found in nature on that plant that I just showed you before. We use those medications for pain relief. We use them for people who have, let's say, if you have a trauma, a fracture, a surgery. They are very powerful because they will block the pain sensation, especially if it's an acute pain problem. But we are discussing more the chronic use of these medications. And when we say chronic, is at least 6 months, and people are using these medications for years. And there is a possibility that these people will become addicted. So we'll talk about this later. But there are other opioids. They are semi-synthetic or synthetic, and these are the opioids that we have available in Canada. So my tip for you is the first one. If you are taking an opioid or some relative or friend or anyone in your family, and you are responsible for your medications, first thing is know your opioid. Know the name of your opioid, what they do for your body, know the dose of the opioid that you are taking. So that's the first thing. When you go talk to your doctor, you should know this is what I'm taking, this is the dose that I'm taking, and know exactly what are you taking. Okay, so the one semi-synthetics that we have are hydrocodone, hydromorphone, oxycodone, oxymorphone, buprenorphine, and the synthetics are fentanyl, methadone, and tramadol. In terms of what does opioids do to our body? So I don't expect you to remember everything that is in this table here, but just to give you an idea, the opioids, when we take them, our body has 3 receptors that are ready to attach to this molecule called opioid. We were born with these receptors, and they are mu, delta, or kappa receptors. We are all born with this, which means, and there is only one molecule that can activate this receptor, and these are opioid molecules. So when an opioid attaches to a mu receptor in the brain, for example, so one of the effects is meiosis. So meiosis is the pupil will become very constricted, very small. So we know if the person is taking the opioids by looking at the pupils. They will be very small. Another effect of the opioids, and you can see here in the red font, is euphoria and dysphoria. So when the opioids attach to the brain and they activate the mu receptor, they cause euphoria. Euphoria is a very happy feeling. They feel happy, they feel better, they feel powerful. It's a sense of well-being. On the other hand, dysphoria is the opposite. They feel sad, they feel depressed, they feel unhappy, and they don't know why. So that's because the opioid is activating the kappa receptor in the brain. Other effects of the mu receptor and the delta receptor is the physical dependence, and we'll talk about physical dependence in a minute. But this means that your body becomes dependent on that medication, which means if you take this medication regularly, day after day, maybe after 2 weeks, as soon as 2 weeks, the body becomes dependent, which means if you want to stop, you can't stop abruptly, you have to stop slowly. And if you stop abruptly, you will have some withdrawal symptoms. We'll discuss those later. The other effect of opioids in our body is respiratory depression and sedation. And that's usually what causes overdose. That's usually what kills people, because sedation means they sleep, they are sleepy, and they fall asleep. And respiratory depression means they breathe slower and they breathe more shallow, their respiration, and they breathe less oxygen, and there is less oxygenation for the brain, and then they die. So And this is a mechanism of the opioids receptors on the mu and the kappa receptors. The other effect of opioids when they activate the delta receptor is the antidepressant effect. So they regulate our mood. So if a person has depression, low mood, and they take an opioid, they may feel better. Their mood may improve. They may feel less sadness. And it's unfortunate. This table here shows, this study was done and published in 2009, and they showed that people with depression were using more opioids than people that were not depressed. And it's bad because we know that depression is a risk factor to become addicted to these medications. So if and we know pain and depression, they come together, and we need to treat both. But we have better medications to treat depression than to use opioids. But some people will say, well, but if you have one medication that can treat both, isn't that a bonus? I can take one pill and I treat both. No, it's not a bonus, because if a person is depressed, their chances of becoming addicted to this medication are much higher than if my mood is normal. But if you see here in this profile of people, they looked at more than 30,000 users of opioids, long-term opioids, at the Kaiser Permanente of Northern California. And we see that the average dose of opioids was higher among the depressed compared to the non-depressed. The number of people using more than 100 milligrams of morphine equivalent a day was almost double the dose, double the rate of people not depressed. Also, the average day supplies was higher, and the use of Schedule II medications, which are strong opioids and medications that can cause addiction, was higher. So, another tip. You need to know, are you using these medications? Are you depressed? If you are using opioids, I tell my patients, I can prescribe opioids to you even when you are depressed, but we need to be much more careful and watch for your behaviors and watch for your sensations. And we should not be using the opioids to treat your depression. We have better medications. So, what are endorphins? Endorphins are like our own endogenous morphine. Our body produces endorphins, and they go to those same receptors, the mu, kappa, and delta, and they activate those receptors. And in which situations we produce endorphins? They are produced when we do exercises, or when we are excited, or even when we have pain, a very excruciating pain that can release our own endorphins, or when we consume spicy food, like things containing capsaicin, or when we are in a very passionate and love or have orgasms. These are all situations that can release endorphins. So they are a natural part of our body or physiology. And they produce the same, exactly the same effects in our brain as the opium or morphine or codeine. So I'd like to talk a little bit about what is opioid dependence and addiction. So I mentioned in a few slides before that our body develops dependence, physical dependence, even after 2 weeks that we use this medication. So what is physical dependence? Is that the body adapted to the drug, and if we stop that drug, the body will ask for that. So it will have withdrawal symptoms. It may start as soon as 2 weeks, and it also not only occurs with opioids, but if we use steroids every day, and there are people that they use prednisone to treat some rheumatic diseases, and they use every day, if they stop the steroids, their body will suffer and will suffer from the lack of steroids. Also, benzodiazepines, the sleeping pills, they also cause physical dependence in our body. So what are the symptoms of withdrawal symptoms of opioids? So early on, in the first few hours that we are not taking the opioids, our body will become agitated. The person will become very anxious. There will be some muscle aches, tearing, insomnia, runny nose, sweating, yawning. So they describe this like a big flu. they describe like, oh, it looks like I'm getting a cold, you know, it's a big, symptoms like a flu symptoms. And if they continue, the symptoms don't get better, they start getting worse, and they can get abdominal cramping, diarrhea, their pupils dilated, they have goosebumps, nausea, and vomiting. The interesting thing about opioid withdrawal is that it's very bad. The person has the sensation that they're going to die. That's what they describe, especially if they were on a very high dose of opioids for a long time. They describe, I feel like I'm going to die, but they don't die. So the feeling is horrible, and if they want to go cold turkey and stop the opioids, that's what they're going to feel. And but it's going to last maybe a couple of days or weeks. In some people, they may say even months, depends on how long they were using this medication. So what we advise people is, if you want to stop the opioids, when it's time for us to stop your opioids, we will decrease gradually the dose, so then you don't have these withdrawal symptoms. It's not easy, it's hard, but it's possible. And we decrease very slowly. We call this a tapering protocol, and we go very slowly, and we are able to achieve this. But the thing is, withdrawal from opioids, they don't kill a person. What kills a person is overdose. So know your signs of dependence and withdrawal. So a person that is taking opioids for a long time, when you don't take your dose, maybe because you forgot to bring your medicine, or because you're traveling and you forgot to take it and you can't buy, did you notice these symptoms? Did you notice withdrawal symptoms? What do you do? How do you respond? Do you get agitated? This is not the same thing as addiction. This is physical dependence, okay? So addiction is this next slide. So this is addiction. We call this psychological dependence. So what are the signs of addiction? Craving for the drug, panic when the drug supplies run out. You need to take the drug to feel normal, so your brain is not working more normal if you're not taking the drug. The person is using the drug as a means to deal with stress, irritability, or unhappiness. And even when they're told they are addicted, the patient is told, you know, this is harming your body, it's harming your life, it's harming your family, it's harming your whole situation. They continue using, they continue seeking for the pills despite knowing that this is harmful. So this is the definition of addiction. So my fourth tip for you is, do you have any signs of addiction? And these tips that I'm giving here are important. Take note of them. I will revisit them at the last slide. I will put all of them together. But these are things that I encourage my patients to come and talk to me. Are you feeling this? This is what you're having. Are you having dependence or addiction? And let's see how we can help each other, because if the patients are not open with me, they are not being honest with me, I have no ways of helping them. What are the risk factors for addiction? So what are kind of predictors that a person will have that will put them at a higher risk of becoming addicted to opioids? So if a person had experimented illegal street drugs before, for example, heroin or cocaine, that puts a person at a higher risk of becoming addicted if I give them these opioids. Also, if they had a previous history of addiction to alcohol or another substance, could even be a sleeping pill, benzodiazepines, or even previous history of addiction to opioids, that puts them at a high risk. If the person has taken someone else's prescription opioid for pain or to see how it made them feel, that also is a risk factor. If they have taken a prescription opioid for a condition that has improved, but now they still need to take the drug to feel better, to continue having the same feelings. If they are currently depressed, if they have a mood disorder or other psychological diseases, that also puts a person at a high risk of addiction. Or even if there's a family history, it has to be a close relative like father, mother, siblings that had a history of substance abuse, such as alcohol, illegal drugs, or prescription drugs. And if the person had a strong psychological trauma in their life, for example, when they were a child, they were sexually abused, or they were a veteran from a war, or they had a PTSD, post-traumatic stress disorder. That also puts a person at a higher risk of addiction. So know your risk factors and talk to your doctor, the person that is prescribing your opioids, about your risk factors, and ask the physician, am I at risk of becoming addicted to these medications, and how are you monitoring me so then I don't get addicted? So one of the myths about opioids is that addiction is rare in patients receiving medically prescribed chronic opioid therapy. The fact is that the estimates vary between 4% and 26% of patients receiving chronic opioid therapy. They will have an opioid use disorder. And it was interesting that among those patients without an opioid use disorder or without an addiction, more than 1 in 10 misused the opioids, which means that there was some intentional over-sedation. They were taking more than prescribed to be able to sleep, or they were concurrently using alcohol for pain relief, and we know that mixing alcohol with opioids is not a good mixture, or they were hoarding the medications, or increasing the dose on their own, or borrowing opioids from their friends. We know this was a study done at CAMH, Center for Addiction and Mental Health in Ontario. So they looked at 571 people that were admitted to opioid, they were addicted to opioids, and they were admitted to this medical withdrawal management service, which is a detoxification of opioids. And if you see here, the number of people that had been addicted to heroin is the gray bar, has been kind of stable over the years between 2000 and 2004. But look at the number of people in the black bar, which is the control-release oxycodone, has increased dramatically. Also, the same thing happened with other oxycodone products and other prescription opioids. So the number of people looking for treatments of addiction to opioids has increased, and this was in 2004, and I know that the data from 2010, 11 are even higher than this, but they didn't publish yet. Also, the source of these opioids vary by age group. They found that if a person was younger than 25 years old, where they were obtaining these opioids were mostly from the streets. But look at the bar of people above the age of 55, where they were getting these opioids for their addiction. They were getting from prescription, from physicians' offices. The white bar is prescription only, and the blue bar is prescription plus from the street. The other myth about opioids is about overdose. So what is overdose, opioid overdose? So first, overdose kills. Overdose is what a person will die from if they have an overdose. It means that the signs of overdose is they have a slurred speech, they start drawling, they're emotionally labile. The ataxia means they don't walk perfectly, they have a balance problem, or they start nodding off during conversation or activities, they're very sleepy, they fall asleep and they don't wake up. Opioids can cause overdose because the dose may be too high, so a higher dose, and we know that control-release tablets, they have much higher dose than the immediate-release tablets, or even parenteral administration. Parenteral means not by mouth, so intravenous or the patches. Or maybe the individual has some risk factors for overdose, which means they are elderly or adolescent. They're also on a benzodiazepine, which is a sleeping pill, or they have a renal or liver impairment. They have chronic obstructive pulmonary disease, or they have sleep apnea, sleep disorder, cognitive impairment. They may be people with dementia. They don't remember that they took one pill, they took another one. Or they mix with alcohol. So the myth about overdose is that overdose only occurs among drug abusers or patients who attempt suicide. That's not true. We know the patients using prescription opioids are at risk of unintentional overdose and death, and this risk increases with the dose and when opioids are combined with other central nerve system depressants like benzodiazepines and alcohol. So just to give you a sense of statistics, in Ontario between 1991 and 2004, there were 3,406 people whose deaths were related to opioids. And when the authors of the study looked at were they suicidal, were they unintentional, you see here that 54% were unintentional. It was an accidental death, 54%. And these were the opioids that were associated with these deaths. But then it was interesting. They found that the number of deaths were related to the introduction of oxycodone in the provincial formulary. So oxycodone was approved by Health Canada since 1991, but it was only 1999 that the Ontario Drug Benefit approved, so people were getting more and more. And look at the number of deaths related to opioids. They increased a lot after the introduction. So it's clear that there is not only the drug addicts and people that were dying from overdose are people that are taking these medications prescribed by physicians. And they also looked at these people that died. Did they see a physician? Yes, most people, 66% of these patients who died, they were seen by a physician in an outpatient clinic or setting at least once in the 4 weeks before their death. And the average number of days was 11. So 11 days before they died of an overdose, they saw the physician. So unfortunately, there was a missed opportunity for prevention of these deaths. So in Canada, we developed this Canadian opioid guideline. I was the leader of the research team that developed this document. It's a document for physicians, nurses, pharmacists, for anyone interested in the topic, but basically to guide the prescribers how to prescribe these medications safely and effectively. Anyone can download the PDF in this website here. And there's also, if you have an iPhone, iPad, or Android, you can download an app for free that contains the full guideline. And I developed the Opioid Manager, which is a tool based on the guideline. It's a 2-page tool you can also download from this website that helps to condense everything that is important to remember from the guideline. So the Opioid Manager is translated to French, Portuguese, Spanish, Farsi. We are entering the social media with the YouTube, Facebook, Twitter page. We have also adapted the Opioid Manager to many electronic medical records to facilitate the physicians to put this at use. And we also developed an app for iPhone and iPad. This is the paid app based on the Opioid Manager. So what the Opioid Manager recommends is that before the physician or the prescriber does the first prescription, there are some things that we should be doing. Know the pain diagnosis. So do you know your pain diagnosis? Do you know why you are taking this medication? Also discussing the goals with the patient. What are your goals with this therapy? Because if your expectation is that 100% of your pain will be relieved with this medication, this is rarely achieved. Look at one of the studies that we included in our meta-analysis for the guideline. This is a study published in 2009 where they looked at morphine compared to placebo. And if you see the improvement, the white bar here is before they took the placebo, and this white bar here is before they took the morphine. Their pain was about, let's say, 6.8, almost 7 on a scale from 0 to 10. After they take the placebo, their pain goes down to approximately 5 in the placebo group, and it goes down to approximately 3.6, 3.8 in the morphine group. So it's not a miracle drug. It's not going to improve 100% of the pain. And this graph here is from one study, but we see this over and over and over, and we did a meta-analysis of 62 randomized trials, and they all look similar to this one here. So the improvement over placebo is not that huge. So we have to tell the patient, on average, this pill will give you 30% pain relief. And also, we have to discuss the patient's overdose risk. We have to know, is this patient at a high risk of overdose, yes or no? We also need to discuss the risk of addiction, and there is a tool that helps us to guide our thinking if the person has aberrant behaviors, a risk for aberrant behaviors, which are in the pathway of addiction. It doesn't tell us who is going to become addicted or not, but it guides us in those questions that I mentioned before. Also, we have to explain the benefits, the adverse effects, give some information to the patient so they can bring home, read. We recommend to sign a treatment agreement and do urine drug screenings. So have you been informed, and did you make an informed decision before you were put on opioids? You can talk to your physician about that. Now, if the physician decides to prescribe opioids, here is a guidance about which opioids to select, which dose to start, and how to titrate. There is also a watchful dose that if the physician decides to go beyond 200 milligrams of morphine equivalent a day, there should be some warning signs. So do you know your daily dose of opioid in morphine equivalent? Do you know how much are you taking? Is it a low dose, high dose? Is it above 200? Is it below 200? And what to monitor on every visit when you see the doctor. These are the we would like you to remember to talk to your doctor about your adverse effects, your pain levels, your functional levels, and if you're having any signs of aberrant drug-related behaviors, which are indicative of addiction. So do you know what to monitor? Do you know what are the adverse effects and complications of opioids? We also should tell the patient not to drive during the trial of opioids. So when we are adjusting the dose of opioids, we should recommend the patients not to drive until we achieve a stable dose of opioid. So driving under the effects of opioids is dangerous. How do we know when we achieved an optimal dose, that the dose doesn't need to be increased anymore? Did you achieve an optimal dose? This is the definition. Optimal dose is when the opioid has been effective, which means has improved the function and it has been at least 30% pain reduction. The effectiveness plateaus, which means increasing the dose doesn't give any increased analgesic effect, and there are no major adverse effects or complications. So these are the 12 tips about talking to your doctor in a summary. Know your opioids, know if you are depressed, signs of dependence and withdrawal, signs of addiction, risk factors for addiction, what is the pain diagnosis, what are the goals, have you been informed about all of this and did you make an informed decision, what is your daily dose in morphine equivalents, what are the adverse effects and complications that you have to monitor, did you know that you should not be driving once your dose is not stable, and did you achieve an optimal dose? So to finish this, and I'd like to have some time for discussion, the question that I posed in the beginning was, are opioids a friend or a foe? So when we look to this horrible picture here of this car crash, I don't know what happened exactly in this accident, but I can imagine if the driver that was in the car at the bottom, if there was a family at the car at the bottom, they were trapped for how long? Maybe a couple of hours under this other car. Maybe they were innocent victims. They didn't do anything wrong, and the other car that came on the top of them did something wrong. I don't know, but I'm just guessing here. So cars could be our friends because they take us places, they help us in our daily lives, they help us to get to from point A to point B, they help us to travel, to be happy and to enjoy our life. But in a situation like this, there are innocent victims. It could be because of the road conditions or the car condition. There are also good and bad drivers. Also, the driver's age can be related. We know that the number of car crashes is much higher per kilometer driven in teenagers and also in elderly drivers. We also know that the driver's experience counts a lot. If they follow the handbook, if they follow the road rules or not, if the driver has a cognitive impairment, if it's a person that is willing to take some risky behaviors, or even if they mix with alcohol, they could be causing all kinds of problems. The same thing happens with opioids. We all remember Whitney Houston, I forgot his name, but there might be other innocent victims and people that died. They didn't do anything wrong, they were taking their opioids as prescribed and they had an overdose and they died. Yes, that's possible. Also, there are people with mood disorders that could be taking these medications just to treat their mood, their depression. It also depends on the type of opioid. Some opioids seems to be more addictive and cause more problems than others. But there are also good and bad physicians, good and bad patients, I would say, too. I can't control what my patients do with their medications once they leave my office. And the pharmacist will say the same thing. I can't control what they do once they leave the pharmacy. There's also patients' age-related factors like too young or too old. They are either high risk. Physicians' experience in prescribing and talking about these medications. If the physicians are also following the guidelines that I mentioned before or not. If the patient is cognitive impaired. Also, if the patient is willing to take a risk. Sometimes, you may think when you're driving, and I would confess here that I have done this. Sometimes I'm driving and I say, oh, I need to make a phone call, and I get my cell phone and I'm trying to make the phone call while I'm driving. That's not perfect because it distracts, it takes away your concentration on the road, and that's a risk that I take. So sometimes patients may take some risks with their opioid medications too. They say, well, I always took these medications. I don't think it's going to harm me. If I take this with alcohol, I'll try. And that's what is fatal for them. So I'll leave for you to decide if opioids are friend or foe for you. And I am happy to entertain some questions and to discuss with your audience some of your interests.
Great. Thank you very much, Andrea. That was a very good presentation, very informative. And I think you touched on a lot of really important issues, and I really like the correlation of the cars being friend versus foe as well as the opioids being friend versus foe. Gives some good context for thinking about the discussion. I think I'm going to ask Lisa if she wants to ask a couple of the questions that have been submitted to us.
Sure. One of the ones that's come up from a couple of different people is how we evaluate or calculate the morphine equivalent of other opioids. Some people are asking about a specific one that they're on and they don't know how to find that out. Can you, any thoughts on that?
Okay, yeah, that's a good question, and it's interesting that many physicians, they also don't know how to calculate the morphine equivalent. So we put that in the Opioid Manager. If people want to download the Opioid Manager, they can go to the McMaster website. They just can Google Opioid Manager or even go to the Facebook page here. And it's free to download the paper Opioid Manager. And on the second page, there is a table that tells how to convert from one opioid to another one. But I'll just give an example. So if a person is on oxycodone, you have to calculate all the dose of oxycodone that you are taking in a day. So the short-acting oxycodone, like the Percocets, they have 5 milligrams. So you have to say how many tablets you are taking in a day. Let's say that you're taking 5 tablets, so that's 25 milligrams. And then if the person is also taking some long-acting oxycodone, which is the oxyneo, they have to add that too. So let's say a person is taking 20 milligrams of oxyneo 2 times a day, plus 5 Percocets. So that's 40 from the oxyneo, plus 25 from the Percocets, so that's 65, correct? So then in order to calculate the morphine equivalent, they multiply, because the conversion from oxycodone to morphine, you multiply by 1.5. So this means 65 plus half of 65, so that would be 65 plus 32, that's 97 milligrams of morphine equivalent a day. So that's how you come up with your morphine equivalent a day. Okay?
Okay. And a question of what are the signs for opioid-induced hyperalgesia? Maybe you could explain what that is.
Okay. So I briefly talked about the complications of opioids. I didn't have a slide about this, but the complications of opioids are what do these opioids make to my body if I use them for a long time, and especially in high dose? So the three complications are hypogonadism, the sex hormones go down. So in a woman, this may cause infertility, amenorrhea, their periods stop, and the men, they may get impotence. The other complication of opioid is sleep apnea. They may develop sleep apnea, which is when they're sleeping at night, they don't breathe properly. And the third complication is opioid-induced hyperalgesia, which is a pain caused by opioids. So if a person takes opioids for a long, long time, especially on high doses, this is not usually seen on very low doses, they start getting a pain in other parts of their body. This pain is kind of a superficial pain in their skin and subcutaneous. They get hypersensitive if someone touches them, if someone presses them, if someone comes and gives them a hug in the arms, and they feel pain. So that's a hyperalgesia, and it may be caused by opioids. Okay.
Okay, there's a couple of questions. I don't know if you're comfortable addressing this one, but about what are the opioids that cause addiction more often and some that are less addictive?
Okay. Of all the opioids that we have in the market, we know that oxycodone, the control release, the OxyContin, the old OxyContin that we had in Canada, was one of the worst opioids for causing addiction. And we didn't know this when the OxyContin was released in the market in the 90s, because nobody knew that it was going to cause this problem. But there were some properties in the OxyContin tablet. For example, 1/3 of the oxycodone contained in that tablet was released immediately. So imagine if a person was taking a tablet of 80 milligrams, then suddenly they were taking like a 5 Percocets, equivalent to 5 Percocets immediately, and that gave a big high in their brain. Now, with the new formulation, the OxyNew, they removed that factor, so apparently they don't have that 1/3 release immediately anymore. And also, it's not a crushable tablet. It's harder to crush. Having said that, every opioid has a potential for abuse, even codeine or tramadol. But apparently tramadol and codeine in Canada, they are not so popular for addiction, and they don't cause a lot of addiction. But in other countries, they may be very addictive. It depends on what the street value is, what other people are abusing around you. All of these social factors also influence which opioids will have a much higher risk of addiction.
Okay, some questions of what are the long-term effects of opiates on your organs? Can they be taken for years as prescribed? And what's known about permanent liver or kidney damage?
Okay, so those three complications that I mentioned before, the hypogonadism, the sleep apnea, and the opioid-induced hyperalgesia are the only three ones that we know that opioids can harm your body if you take them for a long time. Opioids are very safe in terms of stomach, so compared to anti-inflammatories, opioids don't cause any bleeding in the stomach or the bowels. They don't cause any liver toxicity, except if they are mixed with acetaminophen. So some tablets of opioids, for example Percocets, they are mixed with acetaminophen, which is the Tylenol. And the acetaminophen is toxic to the liver. But if you are taking an opioid that is not mixed with acetaminophen in the same tablet, then it doesn't cause any damage to the liver or the kidneys or the stomach or the bowels. Now, if a person has a liver disease caused by something else, they should be careful when they take the opioids, just because the opioids are going to be metabolized more slowly and they are going to accumulate more in their body, but the opioids don't cause liver damage. Okay?
Someone asking, how do I address concerns of addiction with my GP? And this is from an occupational therapist. And do you have any tips about that?
Yes, I think the first and most important advice that I can give to someone is be open, be honest, be clear when you talk to your physician. open up your concerns and say, you know, I'm concerned about this. I heard about this in the news all the time, and I'd like to know, am I at risk of becoming addicted? Do I have any signs of addiction? Do you think that I'm getting addicted, or some of my relatives or family members? The physician, rarely, I would say, the physician would not be responding positively if the patient comes with very honest questions. I know some physicians are very careful, and they don't want to cause more harm, and they may say, oh, even if you have one factor that causes addiction, they would not prescribe opioids. But that's, you know, that's depends on each physician. Some physicians are more cautious, some physicians are more liberal, but we all have a tendency that we don't want to cause more harm, and creating addiction is a big harm in someone's life. So be open, bring the list of symptoms of addiction, check yourself, are you developing some of those symptoms, bring that list to the physician and be open.
Okay, a couple of people are asking, is it true that people need to stay on opioids for a long time to get benefit? Patient questions.
No, you can't. No. I have seen patients that they have a pain episode. Let's say if we talk about a rehabilitation setting, and we start to give them opioids today, and tomorrow they start feeling the benefits right away. It just may take some time, a couple of days or weeks, to adjust the dose to get to that optimal dose. But no, they start feeling the benefits right away. It doesn't mean that they need to be on years and years to start feeling the benefits. If you have been on years and years on these medications, on opioids, and the patient is still suffering from pain, and I've seen a lot of cases like that, they are still in pain, they are still not functioning well, and they are on high doses of opioids, I don't see why that person is on that medication, except that this person may be dependent on that medication and it's very difficult to stop, and that's the only reason, but it should not be the case.
A question about Demerol and how it fits into the mix, if it's more or less addictive?
Yes, okay. Demerol is not indicated to treatment of chronic pain, period. We have Demerol oral medication, and there's also Demerol injection. So Demerol injection, absolutely no for chronic pain. Demerol oral medication, also a no, because when you give Demerol to a patient, you never know. There's a lot of variability in how the dose will be. The plasma levels will be in the body, will be very variable. The metabolism varies a lot. Sometimes it will be high, sometimes it will be low. They are very addictive, so we try to stay away from Demerol to treatment of chronic pain. I know that in some acute care settings, when people come with a very severe acute pain, let's say a kidney stone, an injection of Demerol is could be indicated, but not in chronic pain.
Okay, a couple of questions about laxatives and the side effect with opioid therapy, and is it always or commonly prescribed for people with chronic opioid therapy?
Okay, that's a good question, because the constipation caused by opioids doesn't affect everybody. It affects approximately 30–35% of people that are using opioids every day. So in my case, when I'm prescribing opioids, I usually don't prescribe the stool softeners or laxatives right in the beginning. I wait to see if the person is going to need or not. If we need to go on high doses of opioids, most of the cases they will need some stool softeners or laxatives, but it's not always. So my tendency is to wait and see how bad it is. Sometimes it's very manageable with just increasing the intake of fluids and fiber, doing more exercises, and they don't need to take medications to manage this adverse effect. But when they need, if they are getting blocked, their bowels, we have a couple of options. There is now an opioid in Canada that is available that it has less effects on the bowels because it's mixed with naloxone. And also, we can also prescribe also a laxative or stool softener at the same time as the opioid. So they are manageable. If the opioids are given in very high doses, and when I say very high dose, I'm talking about more than 200 or even 500 milligrams a day or thousands, then the bowels get really hard to manage and we need to be very aggressive. Okay?
A couple of questions about specific medications, asking your opinions on using Matadol for chronic and acute pain and your thoughts on methadone and the use for pain management.
Yeah, so these are drugs that are available in Canada. The thing is the physicians need a special license to prescribe methadone. And the special license is because methadone can be very, can cause more harms in terms of over-sedation. It's difficult to adjust the dose, and there's a higher risk of causing overdose and deaths. So not every physician is comfortable and have the training to prescribe these drugs. And but when you find a physician, these medications, they have some properties that are analgesic. They improve pain, and also they are less addictive, and they are much cheaper than the other opioids, the newer opioids in the market. So they have a lot of advantages, but it has to be prescribed by someone who has a special license and has experience in doing this.
Okay, thanks, Andrea.
Yeah, I think our time is up. Andrea, thank you so much for your presentation. It was very, very wonderful. And if we do have any questions, would you mind if we follow up with you about those?
No problem, no problem. I'll be happy to respond by email or
Wonderful.
and then you can post on your blog.
Wonderful. That's fantastic. Thank you so much.